Hello, and thank you for joining this webinar on chronic pain management for those living with spondyloarthritis. My name is Brenda DeLauder, and I am the Executive Director with the Canadian Spondyloarthritis Association, and I'm delighted to be the moderator for today's event. Please feel free to let us know where you're joining us from in the chat feature. We would also like to ask that you use the Q&A function in the Zoom webinar console to ask questions. Now, we may not be able to get to all of the questions, and if we don't, we will be sure to address them following this event. And again, please share where you're coming from. I am going to share my screen. Excellent. I would like to begin by acknowledging the Indigenous peoples of all of the lands that we are on today. While we meet on a virtual platform, we take a moment to acknowledge the importance of the land which we call home. I'm coming to you from Hamilton, Ontario, and which is part of the treaty lands and territory of the Mississaugas of the Credit. We recognize that those joining us are doing so from across various lands and territories. For thousands of years, Indigenous peoples inhabited and cared for these lands and continue to do so today. We are grateful to have the opportunity to work and live on this land, and by doing so, we give our respect to its first inhabitants. So most of us are all far too familiar with spondyloarthritis, and really it describes this group of chronic inflammatory diseases with common features such as inflammation of the spine, the eyes, and the GI tract. And these conditions are painful, they are debilitating, they are life-changing, and especially for those with disease progression. And it takes a toll on loved ones, and most patients begin experiencing symptoms between the ages of 17 and 45. So here at the Canadian Spondyloarthritis Association, the CSA, we're focused on three main objectives: reducing time to diagnosis, awareness and patient education, and advocacy to influence policy. And today, as one of those objectives, we are bringing to you this educational segment on chronic pain management treatments. I would like to take a moment to extend our thanks and appreciation to some of our partners. With their support, we're able to provide you with these types of opportunities to help inform and support our community. We also wish to disclose with transparency the funders of our webinar series, as well as acknowledge these partners who make this and the many other programs and services offered by the CSA possible. Thank you very much. I now welcome our expert guest to join me on the screen in just a moment. And as I do so, again, please put any questions in the chat, as well as tell us where you're coming from. So really, it is my absolute distinct pleasure to introduce you to Dr. Max Sun. Dr. Sun finished 3 years of honors pharmacology and completed his medical school training at UBC. He trained in internal medicine residency program at UBC and completed his Royal College Fellowship in rheumatology. Dr. Sun has a general rheumatology practice and also has special interest in interventional pain procedures and chronic musculoskeletal pain management. He practices at both Artis and the Change Pain Clinic. Dr. Sun is a clinical staff member at Mount St. Joseph's Hospital, as well as a distinguished member of the CSA Medical Advisory Committee. Welcome, Dr. Sun. I will move from the screen sharing, and so you can come onto the screen.
Perfect. Hello, Brenda. Thank you for that introduction. I really appreciate it. And thank you for inviting me to give this talk on management of chronic pain. We all understand that chronic pain is a huge issue affecting the population, and especially so in patients with spondyloarthritis. I am now going to share my screen so that you can see my presentation. Perfect. Okay, so today I am going to be talking about a layered care management plan for chronic pain. These are my disclosures. I have 3 objectives for today's talk. Objective number 1 is to really educate our members and the people viewing on the complexity of pain management. Number 2 is I would like to introduce a way of managing pain so that we have a stepwise approach instead of just trying whatever procedure or treatment that's available at the time. And lastly, I would like to give our patients some resources that they can consult to help them manage their chronic pain in their daily lives. So pain will continue to be a major issue for patients in those with inflammatory disease, as well as those with trauma and surgery. So we all know that pain is a huge problem. The incidence of chronic pain is getting higher over time. Some people say that it's a disease of rich Western countries, but I think that really is an oversimplification. There is a plethora of social and cultural implications on the incidence of chronic pain. It is also influenced by the support that a society has to help those who are in pain or who are the most vulnerable. In terms of Canadian statistics, studies show that between 14 to 29% of the Canadian population suffer from some sort of chronic pain. A third of these patients have psychological comorbidities. And the bulk of the chronic pain management is taken by the primary health practitioners, like your family doctors. In terms of workplace pain, WorkSafe BC statistics indicate that there is a over 80% predominance of females with chronic pain affecting their work, and predominantly in the healthcare sector. Subsectors include nurses, care aides, and patient services. Over time, female claims with WorkSafe have slowly increased. Looking at a study published in 2016, it showed that over a 3-month span, 25.7% of patients will experience some sort of low back pain. Risk factors include female sex, older worker, work-family imbalance, hostile workplace, job insecurity, and long work hours. And in general, females suffer more pain during their lifetime than males. We suspect that this is due to some sort of hormone imbalance. Perhaps there is contribution by estrogen, progesterone, and testosterone. Now, the biggest question I always get asked in my practice is, what's causing my pain? Where is my pain coming from? And that is a very difficult question to answer. A lot easier said than done. When I see a patient with chronic pain, instead of trying to find out exactly what the pain generator is, it can be quite confusing. I like to go with an anatomical layer by layer method. I look at the skin, the fascia, the muscles, the ligaments, the joints in the spine, the nerves. All of these structures can cause pain in a certain area. So for example, this is a picture of a patient with shingles. And for those of you who have shingles, you will know that it can be very painful. It can be very sensitive to touch, sensitive to the wind blowing, and sensitive to even wearing clothes. So the skin can be a source of pain. The next layer, which is the fascia layer, has been shown that there are specific fascial disorders that can also cause pain. These disorders include some pathology with tightness of the fascia, thickening of the fascia, lymphedema, which is basically water retention of the lymph in that area. It can also be associated with muscle pain called myofascial pain. Changes in the fascia in research have been shown to alter proprioception, which is basically your body's perception of where your limbs or body parts are in space relative to yourself. And when you have differences and changes or damage in your proprioception, you will also have changes in terms of your motor coordination And that at times can cause muscle tightness, and that can also cause mechanical pain. Now, the next layer deeper to the fascia is the muscle. And this is a classic example that we commonly see in patients with neck pain and back of the shoulder pain. This is taken from a book by Simona Trevel, who one of the physicians who wrote the book was actually the physician to JFK, the President of the United States. They developed a book indicating that certain muscle trigger points or tight bands in the muscle can cause pain not at the location of the tight muscle, but radiates to other areas. And what this slide shows is that if you press on the levator scapulae muscle in certain areas, such as here, the pain isn't just localized to this area, but it can actually radiate to the jaw, radiate to the top of the head. Incidentally, other trigger points in the trapezius and the latissimus here can also radiate to the back of the head and the upper neck as well. So muscle pain can certainly cause a lot of discomfort, not only in the location of the muscle injury or muscle tight band, but also radiates to other areas as well. The same thing occurs in the back, upper back, and lower back. You can see here that trigger points can radiate pain all across the upper back and down to the lower back. Sometimes trigger points over the gluteus maximus muscle can cause pain to shoot down the leg. And trigger point over the tensor fascia lata can also cause a similar pattern of pain shooting down the leg, even though the origin of the pain is here. So going by layer approach on pain management, we can try and tease out which areas of the body could be causing the current pain and could be generating the current pains. The next layer, deeper to the fascia, are the joints of the spine. And the main joints we look at are these facet joints. These facet joints indicated here are the joints that keep the cervical spine, thoracic spine, and lumbar spine in place, so that when we rotate, flex, or extend that area of the body, it doesn't extend too far. It doesn't cause the disc to slip out. It gives us stability. But these joints can also be degenerated. They can also get damaged over time. And when they get damaged, they can also cause pain. And the areas of pain that they cause can be indicated by this graph right on the right-hand side. And what this graph shows is that depending on which joints are affected, it can cause pain in these specific areas. And this has been confirmed by research. So similar issues occur in the lumbar spine as well. You have the lumbar facet joints here. And irritation of these facet joints can cause pain shooting down, not just over where the facet joints are, but it can shoot down the leg. It can shoot down the back of the leg or the side of the leg. Okay. Next are the ligaments. So if we actually take a healthy patient, we stick a needle in the ligament and we expand it by injecting normal saline into the ligament, they will also produce a referred pain. Depending on the ligament being injected, it can also cause pain going down the leg, sometimes even all the way down to the heel of the foot and the side of the leg as well. Next, in addition to the facet joints, we also have the sacroiliac joints. And the sacroiliac joints, when provoked, can also cause pain in a similar fashion down the leg, either from the side or down the back. And then after that, we look at the nerves. I'm sure many of you have heard sciatica. Well, sciatica is more of a layman's term indicating that there is a nerve being pinched. And when a nerve is being pinched, what you generally see is there is a protrusion coming out of the disc, and that is impinging on the nerve. And when it's impinging on a nerve, it causes inflammation. And when the nerve is inflamed, it causes pain to shoot down the entirety of that nerve. Now, this can occur commonly in the neck or in the lower back. It usually doesn't occur in the mid-back as often, mainly because the mid-back is relatively quite stable due to the ribs affecting that area. However, when a lower back nerve is being pinched and you have shooting pain down the leg, a lot of people will call that sciatica. In general, the pattern of sciatica is also quite similar. Starts in the back, goes to the back of the foot and to the heel if it's S1. It goes to the side of the foot and to the toe if it's L5. And depending on whether it's an L4 or L3 and go to the front of the thigh and down to the ankle. or to the knee. So over the last few slides, I've basically shown that all layers of the human body can cause pain. And in many instances, it can cause pain in a very distinct pattern. Now, there's one part of the body that we haven't discussed, and that's the disc. And so theoretically, discs that have been damaged also have nerve endings growing into them. And so disc pain can also occur. And we call that discogenic pain. But there is a little bit of controversy, and not everybody believes that discs can cause pain. Unfortunately, whether this disc can cause pain or not, we do not have any really good definitive treatment for disc pain. And thus, the way to test for disc pain, it's very invasive. And that's why it's not often done. Now, further complicating the matter of finding the pain generator, we also have to differentiate between acute and the chronic pain pathway. An analogy that I like to use is that the acute pain pathway is like a single road down a flat field. You have pain and injury in the finger, you see the injury, you feel the injury, the area just immediately around the injury is painful. You have a pain signal from the site of injury, such as a finger, that travels down the arm and goes all the way up to your brain, and it registers as pain in that area. Now, that is acute pain. Very simple, very straightforward. Unfortunately, in many patients, this acute pain can quickly turn into chronic pain, where the pain area expands. Sometimes people feel that not only is the pain, is the injury site painful, but the surrounding site, for example, the entire finger or the entire hand can become painful. And when this happens, we suspect that the pain signal from the site of injury to the brain has become muffled, and it has become much more complex. And it is not a single root that causes this pain. It's more like several routes on an interstellar highway, all trying to present pain signals back up to the brain. And these changes not only occur at the site of the injury, but it can also occur in the spinal cord, where nerves start transmitting pain over different levels of the spinal cord. So the area of the pain receptive field actually increases, and that we suspect is what's causing patients to feel pain, not just in the site of injury, but spreading to either the entire finger, entire hand, or sometimes the entire limb. And this is when we start describing peripheral and central sensitization. So when we look at and quantify the human pain sensory experience, we initially suspect that there could be an initial nidus of injury right here. But in some patients, rather than having the acute pain pathway where the injury and pain is localized to that one area, it starts to spread. It takes a bigger field, and over time, it takes an even bigger field, and over time, it affects the entire back, and they're no longer able to isolate the specific pain area or the initial injury. And sometimes this can occur in as short as 1 to 8 weeks. Why it occurs in some people and not others depends on a lot of the risk factors. Risk factors such as a risk factor of childhood abuse, childhood adverse events, previous trauma, underlying depression, catastrophization. There's a lot of events involved that really promotes this kind of progression in their pain symptomology. And given all this now, let's see what the conventional approach to pain has been. So in the past, a lot of people with a lot of pain treatment therapies are usually, if I have a hammer, everything's a nail. We see some physicians do lumbar epidural injections, some physicians do facet injections, some physicians do prolotherapy, some physicians do sacroiliac injections. And every patient they see, if it meets kind of their criteria, they will do the procedure. If it doesn't work, they have nothing else to offer, and the patient goes and seeks elsewhere. And so basically, they have a hammer in their toolkit, and every patient that comes to see them, they see it as a nail, and they try the hammer and see if it works. If it doesn't work, then the patient moves on. So let's see. So the issue with this type of approach is that it's very piecemeal. And a lot of times, patient will see another practitioner who will do the same thing again because that's all that they're able to do. And it's hard for a physician to see a patient and assess them comprehensively, to look at not just the nidus of the pain generator, but to look at their entire holistic self to treat their pain in a more wholesome fashion, which is what's needed in a lot of these patients, especially those with widespread pain and this increase in sensitivity that we just briefly talked about. So let's go through an example of lower back pain. Now, imagine a patient who may have had a history of ankylosing spondylitis. They have a motor vehicle accident. They complain of pain from the lower lumbar spine, radiating down to the back of the thigh and to the foot. If we look at a stepwise approach to pain management, let's see what could be causing pain. Let's look at the diagram again. We can have the skin, the fascia, the muscles, the ligaments, the joints, the nerves, and potentially the disc. So where is this pain generator? Is it in the muscle? Well, it could be. If you have myofascial pain or trigger points in the piriformis muscle, it can also radiate down to the back of the leg and sometimes to the heel. So it could be myofascial pain. Could it be lumbar facets? The pain pattern does fit. Some lumbar facet pain can radiate down to the back of the leg. So yes, it could be lumbar facets. What about this? Well, this is an image for the lumbar ligament referred pain. And as you can see here, some of the ligament damage and ligament stimulation can also cause pain shooting down the leg to the heel. So yes, it could be lumbar ligaments. Could it be aggravation or dysfunction of the sacroiliac joints? Certainly, sacroiliac joint pain can also have a similar pattern going down the leg to the back of the heel. What about nerve impingement? Well, yes, because S1 or L5 nerve root impingement can also cause a similar pattern. The S1 goes to the heel, sometimes the L5 goes to the toe as well. So yes, it could certainly be nerve root impingement as well. And on top of that, you have what we discussed previously, where in some patients, their pain is not localized anymore. It's actually spread to multiple areas throughout their body. And that is due to the abnormal signaling and the complex signaling of pain that has developed over time, where it is not a straight line from the initial site of injury, but a complex interplay of neurons and sensitivity in the central nervous system and the peripheral nervous system, causing this phenomenon that we call, or syndrome that we call, central sensitization. And with central sensitization, some patients will have exquisite sensitivity and tenderness in multiple areas. It can also be associated with severe fatigue, cystitis, pain with menstrual cycles, restless leg syndrome, TMJ pain, migraines, tension-like headaches. So with all of these possibilities, how do we kind of narrow down and find out how to treat this person? Perhaps imaging and technology can save us. Well, we have MRI, we have CT scans, we have EMGs, but unfortunately, none of these imaging and investigation modalities have been successful in trying to isolate the pain generator, either soft tissue pain, facet joint pain, or sacroiliac dysfunction. And so it can be quite confusing. How do we treat these patients where there could be so many areas, so many generators of pain, and we're not really sure? So that's where I think, as part of the Change Pain Clinic, we do a layer by layer by layer approach. This is a graph that I like to show in a lot of my talks. I've shown this before. For those who don't know, this is Frida Kahlo. She is a very famous painter, and she had a very complex medical history. She was in a bus accident at a young age. It damaged her entire spine. She basically lived her entire life in the hospital. She went through multiple surgeries for her back. She had a lot of chronic pain and died at a younger age. This is her painting showing what it's like to be in chronic pain. And what I like to show here is that in addition to what she feels, there's a lot of other issues that can affect people with chronic pain. Many of you have experience with these issues. For example, she has depression indicated by the crying eyes. She has nociceptive pain, which we describe as pain from damage to peripheral structures. So she has a lot of pain, dull ache pain from the surgery from her spine. She has a lot of pins and needles throughout the body, indicating neuropathic pain, burning pins and needles pain. And there is a significant amount of psychosocial isolation, as shown by a lone woman in the middle of the desert. So when we treat chronic pain, it's not enough for us to just give one treatment and to treat the facet joints, for example, or to just treat the sacroiliac joints and move on and see if it works. Because a lot of times these patients have a lot of sensitivities and a lot of other factors that's promoting their pain. So the method that we have is we look at a patient like they're an onion. And we have to really peel back the layers, layer by layer, to treat all aspects of their pain to help them get back to their function. A graph that I like to use is this pain graph. Pain rarely occurs in isolation. In general, when people are in pain, they tend to have decreased functional ability. When they have decreased functional ability, they tend to have decreased mood because they can't do the stuff they used to. When they have decreased mood, their sleep suffers. And when their sleep suffers, their pain gets worse. This is the pain cycle. And for us to really treat the pain, we really need to hit the pillars that keep the pain up. And these pillars of support are decreased function, decreased mood, decreased sleep. There are other external factors that can also aggravate and cause increased pain. Those include work-related stress, social stress, and the source of pain itself. Now, I put the source of pain as an external factor, not as the main factor, because at a certain point, the pain basically self-perpetuates due to further worsening of decreased function, decreased mood, and decreased sleep. And even though in many patients or in some patients, we do find the initial source of pain and we treat it, their chronic pain doesn't actually go away. And if this spiral, if we allow this spiral to go farther deep enough, it will actually turn into central sensitivity where patients will have chronic pain throughout the body, not just at the initial site of injury. So we need to really peel back all of these pillars that are holding up their pain, the sleep, the mood, the function. And that's why at the pain clinics, many pain clinics, including our own, we have a lot of programs to help patients with their movement, to help patients with their sleep, to help decrease their stress, to improve their nutrition. Because we understand that if patients are able to be successful and optimize these pillars and destroy the pillars that hold the pain up, then there's a chance that the pain can come down. And then treating the potential source of the pain will have a much bigger impact. So when we work in layers, we can see that initially patients have low function, poor sleep, low mood, and we get them to attend our online programs. We educate them on pain management. We educate them on supplements and give them some medications to help just dampen that overlying cloud of chronic pain and to help decrease the sensitivity so that we can look deeper into where the pain is coming from. So some of the programs, a lot of our programs that we have are online. They are group medical programs. We have a professional that kind of educate patients on how, educating them on pain versus harm, educating them on treating kinesiophobia, which is fear of movement due to pain, educating them on sleep hygiene, nutrition optimization, mood optimization, positive thinking. All of that really helps. This is basically our program foundation. Now, this is an old brochure. The costs are not there anymore. All of these programs are for free now, covered by our provincial healthcare plan, and we're not running them privately anymore. The goal with these programs is so that you are in control of your pain and you are living well with the pain, and you're not living in pain all the time, letting the pain control your daily life. Some of the supplements that I like to give people with chronic pain and sensitivity include low-dose naltrexone. So naltrexone is a medication we use to treat people with opioid overdose, but we found that at low doses, it can change the glial cells, which are the cells that basically clean up the spinal cord and the neurons. And low-dose naltrexone can certainly help some patients with chronic widespread pain, especially with the numbness and tingling aspect, and it has worked quite well in some of my patients. theoretically, it's an anti-inflammatory compound that can help with the mast cell. Another supplement that I have given some patients is palmitoyl ethanolamide, or PEA. This is a supplement that supposedly can also help with the glial cells, that can also supposedly help with the sensitivity of the body. I have to say it is a supplement. In my experience, I've had some patients who do really well and some patients who have not a lot of benefit. So it is really a trial and error. It can be expensive. So what if patients go through these classes, they're still in pain? What do we do? Well, then we start a layer by layer approach. We look at the skin, no issues, no rashes, no sensitivity. Then the next layer is the muscle and the fascia and the ligaments. And the only treatment we have for those for now are trigger point injections. And many of you might have heard of trigger point injections. Trigger point injections have different forms. It basically involves putting a needle into a tight muscle band and to help the muscle band relax, and thus giving you pain relief from that muscle tension. Studies have shown that it doesn't matter what you inject, it's the needling itself that gives the most benefit. I do tell patients that trigger point injection is not the end-all be-all for treatment. It is there to mainly help you feel some improvement so you can increase your functional ability, so you can increase your exercise, you can increase your muscle strength, physiotherapy. And you cannot rely purely just on trigger point injections to take away your pain. You have to put in the work as well. What if then we have patients who undergo trigger points and they still have pain? Their muscles are constantly tight. Trigger points only last for a short time. They have no long-term benefit from it. Then we look deeper. We look at the facet joints. We look at the nerves. We look at the sacroiliac joints, because then the theory is potentially could these deeper structures be causing pain, and thus causing the muscles overlying those structures to become tight and constantly in tightness. And for these type of pains, we then go on to nerve blocks and injections. We use ultrasound and sometimes X-ray to inject the facet joints. We use it to inject the nerve roots as well to help find the pain generator that can help relax the muscles around that area as well. And if we are able to find a nerve that is causing a lot of pain in patients, our next step is something called radiofrequency lesioning. Radiofrequency lesioning, in this case, is we put a very small needle beside a nerve, and we heat the needle up to about 80 degrees Celsius for about 120 seconds or 2 minutes. In theory, the heat should destroy these small nerves that are causing pain. Now, I know what you're thinking, it sounds scary, but research have shown that these small nerves, burning off these small nerves do not cause any inflammation. Burning off these small nerves mainly decreases pain coming from the nerve itself. And if successful, it can give you pain relief from this type of nerve pain or joint pain lasting 12 months up to 2 years. So this is certainly a step for longer term pain relief if patients are deemed to have pain coming from those nerves. We also do other nerve injections. Some patients have a lot of dental pain and facial nerve pain, and we do specific ganglion blocks in the face that can also be beneficial. We can do it with steroids as well for longer relief. Unfortunately, not everybody responds to education classes, trigger point injections, or nerve blocks. And in this case, we suspect that their pain is not just in an isolated area, but their pain is more diffuse, more due to sensitivity in the peripheral system and in the central nervous system, in the spinal cord. There's increased sensitivity, and there's increased sensitivity in the brain, causing them to always feel pain in that area. Some patients will actually have such bad sensitivity that any injections in the area will actually cause a pain flare. And I've seen that many times before. So unfortunately, we do not have a lot of good methods to treat this central sensitivity. Some people use antidepressant medications. One of the methods that we use is infusion therapy. And we infuse people through the IV or through the skin infuse people with either lidocaine or ketamine. And the theory is when patients get infused with lidocaine or ketamine, their entire body numbs, and it's a reset of their nervous system. Now, it doesn't last forever, and in many cases, the pain does come back, but the hope is it's like a reset to one's central nervous system. When the pain does come back, it comes back in a less severe degree than before. It's basically like taking a computer, shutting it off and turning it back on again in hopes that the previous bad program runs smoothly again once there's a reset. It can be infusion through the IV, or sometimes if patients respond well to the IV, but they can't come in for the infusion, we give them a subcutaneous infusion of lidocaine they can take home, and it infuses them over 36 hours. It's a cheaper option and a much more mobile option. Unfortunately, infusion clinics are very limited. The only government-funded infusion clinic is at St. Paul's Hospital. And unfortunately, St. Paul's Hospital will only take patients from Vancouver Coastal Health. And so a lot of other places will not have access to infusion therapy. We do have infusion clinic at the pain clinic. We're the only clinic that has it in the province. And we're the only clinic that meets the College of Physicians and Surgeons of BC standard for pain infusion clinic. Unfortunately, it is a private pay therapy at the pain clinic. We do have a lot of people who use it, mainly from workers' compensation or ICBC, and we do have some patients pay privately because it's the only thing left to help them with decreasing their pain. And so what I can say is, based from seeing a lot of patients at the Change Pain Clinic, we can't promise 100% pain relief, but we do try our best to go through layer by layer of pain management so that we do not miss anything. And if anything, we are very tenacious in trying to find out a way for people to manage better with their pain. And we usually tell our patients that our goal is not to take their pain away completely, but our goal is to really help them live with their pain, manage their pain, be functional with their pain. And we are quite persistent. And this is an image of blind men trying to feel an elephant. And the person in the front will say, oh, it's a trunk, it must be a snake. The person here said, oh, it's a tusk, it must be a rhinoceros. So everybody feels a different part of the elephant. And this is what conventional pain therapy is like. Everybody does one part in trying to treat a patient's pain, when in reality, all of these people have to talk and develop a plan to get a better image of the bigger problem. And that is how to really properly treat pain. And it can be very difficult to do, but we're trying our best to do it. In terms of some resources for you guys, you're always welcome to look at the Change Pain Clinic website. Anybody in BC are allowed to attend these online classes with a referral from their family doctor. And so they can learn more about how to manage their pain and the basics of pain management. Here are some other resources for people in BC and around the country on self-management techniques for pain, and some of the patient pain networks that they can talk to other people in similar situations. So in summary, pain is complex, and the pain generator can be due to a combination of mechanisms. Unfortunately, imaging and other testing are usually not helpful in adequately diagnosing many pain syndromes. We try to practice a layer-by-layer approach to pain diagnosis and treatment, just so that we try not to miss any possibilities, and really need to try and incorporate early multidisciplinary care and treatment to help patients with pain in hopes of trying to prevent them from going from a localized pain area to more of a widespread sensitivity. Thank you, and I'm happy to take any questions.
Thank you so very much for that very insightful presentation. We do have a few questions here. The first one here that I'm reading, it says, as you mentioned, managing pain is very confusing. Do you have any suggestions for collaborating with a healthcare provider or your doctor for pain management?
Yes, it is difficult in the current landscape, mainly because family physicians who take the heaviest burden of pain management are so overwhelmed with everything. I think one advice I would tell patients is to really try and work together with your doctor, to really try and have a doctor, allow the family doctor to be by your side to help advocate for you. And it's hard not to be frustrated with your practitioners sometimes because living in pain is absolutely awful. And I would recommend that patients themselves have to also be their own advocate. I recommend attending resources in your province, perhaps attending online classes as well, learn about pain management, and then having a discussion with your family doctor, maybe letting them know what you think are things that could help you and see if your family doctor agrees. And she or he could perhaps give you advice on how to further go forward, either refer you to a pain clinic or give you other resources. But you have to be understanding and work with your primary practitioner because it's easy to get overwhelmed with chronic pain as a patient and as a doctor.
Yeah, that's great. And connected to that question, I have another one here. I've been told that patients tend to underreport symptoms and pain. Why do you think this is? And do you have any advice for those who do?
That's a complex question.
Mm,
I think a lot of it really comes from the stigmata of chronic pain patients. A lot of chronic pain patients have been told it's in your head, or you're just depressed, or oh, it's just fibromyalgia, it's a psychological issue. And that really adds a negative stigma to having chronic pain. And I think that really prevents some people from really voicing the difficulties they have with their chronic pain management. And it's really unfortunate. The one advice I like to tell patients and people who are watching this is having chronic pain is not all in your head. That is absolutely not true. And that's been scientifically proven. I'm not saying that you need to argue with anybody who says it, but I think you need to know yourself that if you're having difficulty managing with chronic pain, you need to tell your healthcare provider that, hey, I am having a lot of difficulty. Help me and find resources or refer me to clinics that can help me deal with my lack of ability or my issue with chronic pain. And because it is a very difficult issue. And I think people need to know in their mind and in their hearts that, hey, this is not just psychological. This is not just depression. This is a real pain, and I have to be open to treating it holistically, but it is not just in my head. I am validated.
hmm. Validation, that's a term that we use quite frequently here at the CSA. And so I have another question here, and the question is trigger point injection similar to acupuncture?
Mm, very good question. There are many different types of trigger point injections, and there are many different types of muscle injections. So
Mm,
let's take a step back. Muscle injections, I use the term as anything where you input something into the muscle. Trigger point injection specifically is you find a trigger point or a taut band in the muscle and you inject it with a needle. That is a trigger point injection. Acupuncture is you take a very thin needle and you put it into areas where there is flow of qi. And it's a traditional Chinese medicine method where not only are the needles you use smaller, but the concept behind it is different. They use acupuncture to put into areas where there may be buildup of qi or other compound that they need to release. They're not going to the specific muscle tightness like trigger point injections. There is also IMS, intramuscular stimulation. And that is, I think, my interpretation is a different type of muscle injection. They put a needle into specific muscle groups and they stimulate the muscle to try and release the muscle. That is what I've been told is IMS. And their concept of where they put the needle is also different. They don't always go for the taut band or for the tightness of the muscle. They tend to look at you generally, and they go for muscles which they think could be causing the pain in a different area. So they're all putting needles into the muscle, but the concept is different, and it can be very confusing.
That's great. Thank you so much for clarifying that. Very enlightening. We have several other questions, but I'm going to take the time to ask one more before we close. And this one is, it says, traditionally, the treatment for chronic pain included rest. However, we know that with spondyloarthritis in particular, symptoms can become worse with rest and better with activity. What advice do you have for people who are fearful of more movement because of the pain?
Very good question. And this is a term we specifically use called kinesiophobia, fear of movement. The bed rest for pain really came on because in acute pain, for example, a fracture, you really need to, at least in the initial period, not do too much activity that can cause the fracture to be displaced. But now the paradigm has completely shifted. Even with fractures after surgery, the key is to move, move, move. And I tell a lot of my patients, and our education classes also reiterate the fact that chronic pain does not mean chronic tissue damage.
Hmm.
Acute pain can be associated with tissue damage. Chronic, or what people call persistent pain, is not associated with tissue damage. It is an abnormality in the pain perception, abnormality in the pain transmission. It does not mean that you actually have an area that's being damaged. So we tell people that you really have to understand, if you're moving and you're having pain, it doesn't mean that that area is getting damaged. You should keep on moving within your bounds, but to try and keep on moving and try to slowly expand your capacity. Rule of thumb I use for patients is, if you do exercise or you move and you have pain afterwards, if the pain goes away after 2 hours, you're okay. If the pain lasts more than 2 hours into the next day, you probably did a bit too much. Doesn't mean that you should stop doing it, but you have to do it within reason, and you have to pace yourself so you can slowly increase your capacity. Movement is key.
That's a really good rule of thumb, the 2-hour rule of thumb. Thank you. So, Dr. Sun, thank you so much for taking the time today to share all of this good information about chronic pain. We know that effective pain management is essential for individuals diagnosed with spondyloarthritis to really enhance their overall well-being and their quality of life. And by your highlighting the causes of pain and some management strategies, it's our hope that it will help to improve daily living for thousands living with SPA, because we know that they face a very difficult and painful journey. And so as we wrap up, I also wish to extend gratitude to the strength and the resilience of the SPA community, acknowledging the power of, coming together to support one another, from the online support groups to the local meetups to the ongoing general support and uplifting. This community really serves as a source of encouragement and validation, just as Dr. Sun had said, validation and hope for those navigating their pain journey. And so for more information, we welcome you to visit the CSA website, which is sparthritis.ca. Thank you, everyone, for joining us today.
Thank you.